All right, I've got 9 o'clock, so we got 15 cases to get through. So I think we're going to go ahead and get started. See, we've got a few people that are actually live and online. So if you want to put your thoughts down on what you think the diagnoses are, go right ahead and put them up in the chat room. I'm going to leave that up just to kind of look at. So our first case is a punch biopsy from, I'm not sure exactly where it's from. You can see that at low power, it's got this dark purplish material in here. And as we go to higher magnification, you can also see that there are some cells in the background that are kind of pale and look kind of like a ghost of some cells here. So I don't know if anybody knows what this material is down here, but this is calcification, calcium. And these are probably shadow cells of pilomatricoma. And there's maybe even a little bit of osteoid here, right over here, for example. Here's a little, this is better for it right over here. So this is bone, and then there's some little bone marrow here. So I don't know if anybody knows what the right answer is on this, but this is an example of osteoma cutis arising in a pilomatricoma. You can just barely make out the residual component of the pilomatricoma with some calcification. And you probably remember the name of pilomatricoma is calcifying epithelioma is the other name for that. It's actually another, call it matrical cyst with calcifications. There's a number of different names that have been applied to this. You look at these things clinically, they just kind of look like little, well, you know what a pilomatricoma looks like. These looks kind of bluish. It's kind of a little cyst-like lesion in the skin. They're often thought to be pilar cysts or other things like that. But if you look at osteoma cutis, it kind of looks as a little, almost kind of purplish lesion in the skin. And if you biopsy them, they feel really gritty. If it's just purely osteoma cutis, basically those often arise at the side of somewhere maybe patients have had acne or something along those lines. It gets sort of dystrophic calcification and eventually turns into bone. And so that's ultimately what happens. In this case, it was really related to pilomatricoma. So it's not anything really to just make sure you can identify bone. Under the microscope, you wouldn't want to, on a board examination, for example, misdiagnose that as some type of a soft tissue neoplasm or something else. So the osteoclast, osteoblast, the bone marrow, all those various things are things that help you there. And the osteoid kind of looks sort of, it's pinkish and a little bit amorphous. But you almost always are going to see some calcification with that too. So that's going to help you if you had something saying the differential diagnosis of amyloid or something like that you were thinking about. Okay, here we've got a shave biopsy, a neoplasm, and a low magnification. You can see that it is benign. It's very small. It's well circumscribed. Is it epithelial or non-epithelial? Based on looking at this, you probably would favor non-epithelial. It doesn't look anything like a squamous epithelial lesion. It doesn't really look adnexal. Certainly doesn't look sebaceous. We've got some normal sebaceous glands here to compare with it. So as we go to higher magnification, you can see that a lot of these cells have a spindle cell morphology. When we think of spindle, we obviously think of non-epithelial. And the most common non-epithelial neoplasms we have in the skin are things like neural, fibroblasts, muscle, and then sometimes you can get vessels. Blood vessels can be spindle cell, both lymphangiomatous lesions and vascular lesions. And then you can sometimes get spindle cells and other lesions that aren't normally, don't usually have spindle cell morphology, like spindle cell squamous cell carcinoma. Melanocytic lesions can have a spindle cell morphology. So those are the main things we think about when we think about spindle cell. And we're trying to sort of distinguish those from one another. You look to see what the sort of shape of the individual cells are like. These kind of look like they're little sort of delicate S-shaped cells here, and that favors neural also. So we're looking at the neural neoplasms. There are a whole number of these lesions. And when you see a little small papule like this on the face, it's got clefts around it, and you got the, these are said to be palisading. They're not really palisading. What they're really talking about is that you've got kind of a lot of cellularity at the periphery, and maybe, you can see it's almost kind of forming these little fascicles that interweave. That's not really truly palisading, but you do have this sort of fascicular pattern in the lesion. And so this is a nice example of so-called palisaded encapsulated neuroma. A plexiform neuroma, Drew's asking this question. If you ever see one of those, if you've ever seen the movie Elephant Man, or you've looked at pictures of the Elephant Man, those are plexiform neurofibromas. They're giant, gargantuan neurofibromas that usually envelop somebody's buttock or their arm or their face, and they deform the soft tissue. So you would never think about that on a small biopsy like this. It just wouldn't even enter your brain. So you wouldn't think about that. So the plexiform pattern is a large, deep, extensive lesion, and it usually is not as cellular as this. So we call this palisaded encapsulated neuroma because it's got a greater degree of cellularity. Neurofibroma has a greater degree of stroma. It's more of a loose myxoid stroma with fewer numbers of cells. So the neuromas like this and schwannomas, even though neurofibroma and schwannoma are both of the same cell type, basically those are going to have fewer cells per unit area than individual lesions that are neuromas. So this would be more in the category of the type of neuroma you might see in a patient that might have multiple endocrine neoplasia that's got multiple neuromas, multiple mucosal neuroma syndrome, something like that. So anyway, just remember that distinction, and that would kind of help you to not really be concerned about something like a plexiform neurofibroma. This is what these lesions look like clinically. They're thought to be nevi or something like that. They're really never thought of clinically. Clinicians don't know this entity. They just take a biopsy of it, and the pathologists know it. So at least you know what it looks like under the microscope. And if you ever get, encounter one of these, you'll know basically what you're dealing with, and know that they often look like a little nevus or possibly an angiofibroma, something like that. They don't have to be treated. They're totally benign, nothing to worry about. If you do stain them, obviously rest 100 protein and SOX10 positive. You can see a little bit of perineurium, which is epithelial membrane antigen positive around these things, but they're pretty much just benign lesions that you just have to kind of know what they basically are. Okay, the next case, I'm going to look at this a little higher magnification. It's a shave biopsy. It's also a neoplasm. And you can see this time, as opposed to the last case, it's comprised of squamous epithelium. So this is an epithelial neoplasm. And is it benign or malignant? Okay, well, we don't know the whole size of the lesion, so it looks relatively small. So you can't use size here. You have to use other ancillary criteria. Can we really assess the circumscription and symmetry? It's hard to do also because we just have a shave and we don't know the size of the lesion. It may be this big, but we just have the top of it. Seems to be a little bit asymmetrical with this power. So we're probably, when we're dealing with something that's small like this, we're going to have to look at cytologic criteria. So as we go to higher magnification, you can see that these cells are falling apart from one another. There's evidence of squamous cornification in the lesion. You can see this is evidence of these squamous pearls in here, and this is keratin that's being formed by the cells. And as you go to highest magnification, you can see that there are some individual cells that are in mitosis. They're falling apart. Notice that there's no acantholytic disc keratosis here. So this is an example of an acantholytic squamous cell carcinoma in this case. Okay, so the differential diagnosis of this lesion would include other things. Could be acantholytic, like solitary acantholytic keratosis or warty disc keratoma. Those generally are going to be more cup-shaped, and they also are going to have evidence of acantholytic disc keratosis. This just basically has acantholysis without really a lot of disc keratosis, and some of these cells over here are pretty atypical. So this would favor, like that mitotic figure right there, this would really favor this being an acantholytic squamous cell carcinoma. It's not, on a board examination, they wouldn't show this to you, because this, they would show you one that would be a deeper lesion that you could assess all the criteria. And if it were a warty disc keratoma, you'd see the obvious acantholytic disc keratosis features in there. So this is also something you generally don't see in a warty disc keratoma, this sort of malignant disc keratosis like we see here with this parakeratosis. That's a little bit unusual for that. So this is an example of an acantholytic squamous cell carcinoma. Usually you're going to see an evidence of solar keratosis in that lesion somewhere. You biopsy these, they just look like any other type of squamous cell. They don't look like anything unusual clinically. But the key on this is to look for the features we talked about, the asymmetry, the lack of circumscription, and then the atypical cells, sometimes even more atypical than we see here. These obviously do need to be treated. Acantholytic Squamous cells, sometimes, especially if they're deeper, tend to be a little bit more aggressive. So you might want to think about sending a case like this over to Mohs or something like that when you're dealing with an acantholytic squamous cell carcinoma. Okay, let's take a look at this one. So another neoplastic-like process, and we'll turn it over here. And we've got a papillated lesion. So it's also an epithelial process, okay? And at low power, it's got all this digitation where the epidermis is thrown into these little papillations and digitations. You've got areas over here where there are some sebaceous lobules. And notice that the sebaceous lobules are not associated with hair follicles. They're sitting there alone in the dermis. And they're, in some cases, you may even see where they enter directly into the epidermis. They dump primarily into the epidermis. They're not associated with any follicles. Over here, you've got what looks like maybe a little follicular hemartoma, almost looks like a little mini trichofolliculoma with sebaceous differentiation. And if you were to look at another area, I don't know, over here, you've even got a little small cyst-like structure. It almost looks like a little mini cheroacanthoma, if you will. So you've got these little hamartomas within the lesion. And so hopefully you guys know what this is. This is an example of a nevus sebaceous. And this is a classic, beautiful example of one. Now, this does not have a syringocystadenoma papilliferum in it. That's the most common abnormal neoplasm or annexal neoplasm that you see in association with these things. We don't have that here. We just got this marked verrucous hyperplasia with the sebaceous proliferation. So this is a beautiful example. Now, this is the kind of thing that they might show you, expect you to get it pretty quickly, and then they might ask you about some of the clinical features of the nevus sebaceous syndrome that's been described. So we get CNS abnormalities and other things like that associated with this. They don't really actually get basal cell carcinomas very frequently. That's also a very common follicular abnormality that we'll see associated with nevus sebaceous. They're really more trichoblastomas than true basal cells. Rarely they can get a real honest to goodness basal cell, but it's really, really rare. And so as a consequence, we don't really feel like you need to excise these lesions today. Back in the old days, we used to tell clinicians that they needed to excise these lesions because they could become malignant, but they really very, very rarely do. And the lesions that do develop in these are usually not true basal cells. So here's a classic example of one clinically. They're usually this kind of orangey plaque. They often do occur on the scalp, and when they do, they're associated with alopecia. So that's nevus sebaceous, pretty straightforward one. And again, these develop, they're usually present congenitally. Now, depending on what time you biopsy them, they're going to look a little bit different with regard to the sebaceous proliferation. If you biopsy shortly after birth, they may have pretty prominent sebaceous proliferation because obviously the mother's hormones are still active in the child. And then as time goes on, those hormones go away and the sebaceous glands get smaller. And then when they go through puberty, they get larger again. So depending on when you biopsy nevus sebaceous, the sebaceous glands are going to look a little bit different. Okay, so just basically things to remember. One other thing to remember is an epidermal nevus. A non-nevus sebaceous epidermal nevus can look pretty much just like the epidermal component without the sebaceous lobules. So, and in fact, sometimes you biopsy epidermal nevus, they almost look like just lots of skin tags just sitting there together. So if you ever get a biopsy or somebody has a shave biopsy, it looks like 5 skin tags at one time, but they weren't snipped off like multiple skin tags off somebody's neck. That's a clue that you may actually be dealing with an epidermal nevus, non-nevus sebaceous variant. Okay, so let's take a look at this. It's a punch biopsy. So now we're not dealing with the neoplasm in this case. And there's either one of two things that we're looking at here. It's either on normal or maybe thickened volar skin, or it's lichen simplex chronicus. So whenever you see a markedly thickened cornified layer that looks like it should be from volar skin, always look to see if there are any hair follicles there, because if they are, then it's not volar skin and it's lichen simplex chronicus. But here, we don't have any hair follicles. So this time, I think we're really and truly dealing with something on acral skin. So let's go to higher magnification. So is this inflammatory or is it a neoplastic process? Well, certainly it's not neoplastic. So we don't see any evidence of any neoplastic malformation here. Everything looks pretty much like this normal volar skin. The epidermis, the cornified layer is somewhat thick. So you might say, well, you know, could this patient have a keratoderma? Could they have like a disorder of cornification? That's a possibility here. But you always want to look in the stratum corneum when you've got something like this to make sure that there's no pathologic abnormality of the stratum corneum. So make sure there's no fungi in there. A lot of times you get biopsies from volar skin to rule out melanoma and it's tinea nigra. You want to make sure there's no bacteria in the cornified layer. Make sure there's no chemical application in the cornified layer. A lot of times you get people that use these henna dye tattoos. You can actually see that under the microscope. It's a blackish brown material that deposits on the surface of the stratum corneum or silver nitrate. So let's take a look here and let's see if we see any evidence of tinea nigra, which doesn't look like there is anything here. Let's look at the very uppermost part of the epidermis and whoa, what have we got here? So we do have some abnormality in the cornified layer here. This is as high as we can go. So that's high enough for you anyway. So when you look at it at this power, you notice that these things are kind of oriented. They're not going side to side like a dermatophyte would go. Dermatophytes like to kind of run horizontally in the epidermis. Candida does like to go this direction, but Candida is like acral skin. You know, Candida likes weepy, wet, moist surfaces, likes the open around your lip there, likes the groin areas. So this wouldn't really be a good location for Candida. And also these are, in this power, H&E, they're basophilic. So usually when you look at yeast, Candida, it's really hard to even see those on H&E. You really got to look higher magnification and they look like little tubes in there. They're kind of spaces. Here you can see that they're basophilic. So that should make you think that they're filled with DNA if they're basophilic. And so we're basically then now we may be looking at filamentous bacteria. So hopefully you guys know what the diagnosis is when you see filamentous bacteria on the outer surface of the cornified layer where they're growing down into the stratum corneum here. Yeah, this is pitted keratolysis or juvenile plantar dermatosis, which is the same disease. One gives you little tiny pits in the skin. The other one gives you this kind of diffuse, glassy, eroded areas on the volar skin. So it's the same process. And the organism that causes it, unless they've changed the name since the last time I studied this, it's in the Corynebacterium family. Corynebacterium minutissimum, I believe, is the one that they call it. And maybe there's a couple others. Corynebacterium sedentarius, I think, is the other name for that. So there's several species that are associated with this, but Corynebacterium is the most important thing to remember. And we all know Corynebacterium is involved in C. acnes and acne. It's a gram-positive filamentous bacillus, so it's not really like a coccal organism like Streptococcus or Staphylococcus. So it's a little bit different now. So these are filamentous organisms. So that's good if you're able to recognize that. You don't really need a PAS or gram or anything like that to make the diagnosis. You can generally do it like that. And this is more the juvenile plantar dermatosis condition. And a lot of these kids have maybe chronic macerated weepy feet. They may have some dyshydrotic dermatitis as well. You biopsy it and lo and behold, you see this. And if it's positive, it's good to know because you can treat that. The organism responds to antibacterials. It responds beautifully to topical erythromycin. So that's one option you could use to treat this is just a topical antibiotic. And you probably need some anti-inflammatories also. But if they do have this going on, you really need to treat the bacterial infection as well. And, you know, it also gets in their socks and their shoes. So they may have to get some different shoes. You really want to kind of clean this up and clean up their environment, if you will, or they'll continue getting reinfected. And then you want to they often sweat, they get hot and everything there too. So you want to try to keep their feet dry as well to treat it. So anyway, it's pretty straightforward. If you look at the pitted keratolysis, that would look similar to that, but instead of that diffuse, scaly, eroded area, you usually get more of a little small punctate structures in that condition. So good example of that. Hopefully, I'm glad Ashley recognized that. That's great. So hopefully the rest of you guys did as well. Okay, so we had something like this a few weeks ago, and I think it really kind of is oriented more like this. So basically, at low power, you see the action is going on down here, and we've got a large, clear hole in the skin. So whenever we see that, we want to ask ourselves, is that real or is it fake? You know, did somebody just chunk something out of there? There may used to be something solid, and it's no longer there. So as we go to our magnification, let's take a look. And yeah, there is something here. And it looks like it's lined by some epithelium. And so whenever we look at a cyst, for example, if it's cystic, it's not lined by epithelium. If it's lined by epithelium, it means it's a real honest-to-goodness cyst. And so we name cysts by what the lining of the cyst is. So we want to see if we can figure out what this lining is here. Well, the first thing we can notice right off the bat is that it does not look like typical squamous epithelium. So we're all used to looking at infundibular cysts where the epithelium is stratified squamous, and it looks like the infundibulum of the hair follicle, isthmus catagen cysts, or tricholimal cysts, where that looks like the area of the isthmus of the follicle, if you will. And then matrical cysts, we get polymatricoma like we saw earlier. So those are the three most common follicular cysts. And then you get hydrocystoma lined by these cells of an eccrine sweat gland. You can get apocrine hydrocystoma or eccrine hydrocystoma. And then you get other cysts. And now we've got one that doesn't have any of the classic linings that we see. We've got this material on the surface that's kind of this wispy material that's kind of breaking off and floating into the space here. The cells are cuboidal and they're lined. There's maybe 2 to 3 layers of these cells here. This may be cilia. I'm not 100% sure that it is, but it may be kind of a wispy proteinaceous kind of material that's being formed here. See, some of this stuff over here you can see is a proteinaceous material. So there may be some cells that are ciliated, but a lot of this stuff is kind of more proteinaceous. And the reason I'm kind of scanning around is I want to see if I can find some air material like right here. Yeah, this stuff here is important that we're looking at. And so this is, some of that may be some dermal collagen, but it may also be some kind of a colloidal material. And so we're looking at here, I don't know if anybody knows what kind of cyst this is. This was actually seen, it's not actually bronchogenic, good idea. This is in the category, yeah, Drew is correct, this is a THRYROGLOSSAL duct cyst. Okay, so good. It looks a lot like the bronchogenic cyst in a way, but that has got true cilia in that situation. Also those branchial cleft and bronchogenic cysts, they'll have more respiratory epithelium. You may even get some cartilage in the wall of the blood vessel. If you see things that kind of look like colloid that's being formed, and maybe over here might be a little better area, that kind of tells you this is primitive residual thyroid tissue that's being formed. So these are sometimes difficult, you're right, to distinguish from one another. The board's not going to spend a lot of energy on these for you, so it's just kind of good to know, but I wouldn't waste a lot of time on these, but it's good to just realize the way that you name cysts and look for the type of lining. And in this case, these are little cells that are residual thyroid cells. You've got this pink cytoplasm in here. So these are little residual foci of thyroid epithelium as opposed to actually true cilia that you'd expect to see in a bronchogenic cyst. So these are usually seen in the midline. So the pediatric dermatologist might ask you about this. So they might actually show you the clinical picture and give you a differential diagnosis of several things and say a cyst in this location would most likely be, and they might put in, say, a branchial cleft cyst or maybe a Wolffian cyst or something like that, which occurs on the thighs of women. And just realize that these THRYROGLOSSAL duct cysts are very commonly seen in the midline, right around in this location. They're usually in the upper neck. They're not usually down quite this far. Those are usually a little bit different. They're usually in this area. That's a pretty good location. And they often actually communicate with the tongue. So if you, remember the way that the embryo forms, the thyroid and the tongue and all that kind of stuff are together, and they kind of start splitting apart as the embryo gets bigger and ages. But sometimes you get these little residual thyroid vestiges that stick around. They form a cyst. But occasionally you'll see a little tiny sort of connection with the tongue. So if you see a little pit on the back of the tongue and they have one of these things, that really can make the diagnosis for you. So anyway, just remember these cysts here. They're usually pretty straightforward. They're totally benign. And they're lined by this ciliated columnar epithelium, but it's not all cilia. Some of that's cilia, but a lot of it is probably some thyroid colloid too that's kind of getting extravasated into the cyst as well. And these are the other items that are the different diagnoses. Dermoid cysts, remember, those have a lot of hair shafts in them. If you see ectopic thyroid tissue, that doesn't really look like a cyst. It's more of a solid sort of lesion. Okay, let's take a look at this one. So we've got a punch biopsy here. And let's see, this one, we got two different areas. So let's look at this one over here first. So notice we've got an inflammatory skin disease again, superficial perivascular dermatitis, and we've got another space here. So this time it's not a cyst. So the question is this real again, or is it sort of fake? And it does have a little bit of material in here. It's not a lot. So if it's a blister, it's, I'm not sure this is a real blister. This may just be a cleft that formed in the skin. There's still a little bit of epithelium here. But then there's some abnormality going on in the papillary dermis. Call that to your attention. So notice this papillary dermal collagen here. Is this normal for you? Well, we've got some ciliary elastosis, but you've also got this homogenization of the collagen bundles. There's no fibroblast here. There's effacement of the epidermal rhescia up here. So anybody know what this pathologic process is that we're looking at right here when you see this pattern? Well, this is papillary dermal sclerosus. Okay, remember, sclerosis is a homogenization of the collagen bundles with a decrease in the number of fibroblasts. It can occur in the papillary dermis or in the reticular dermis. Well, here it's confined to the papillary dermis. Go back to low magnification. The reticular dermis is normal. So what's the diagnosis when we get sclerosis of the papillary dermis with no involvement of the reticular dermis? And sometimes you can get a cleft or even a real blister that forms in these lesions because there's discohesion between the sclerotic papillary dermis and the epidermis. Yeah, this is lichen sclerosus atrophicis, and it can actually sometimes form blisters in some cases. This other piece over here, this section, we'll take a look at it. I don't believe it's got any of the real vesiculation going on here. Maybe a little cleft right here, maybe an incipient one over here. But it's really fairly common because LSNA, you lose that normal cement, if you will, between the epidermis and the dermis when you get all that sclerotic collagen and you wipe out the epidermal rhescia. And the epidermis can get really, really thin. There's the atrophic part. But what's interesting is even though you get a thin epidermis, you can still get a marked thick cornified layer because it's itchy. Patients rub LSNA and they'll complain about pruritus. So you get a thick cornified layer from lichen simplex associated with the sclerosis. Now, if you get sclerosis of the reticular dermis along with it, then we call it morphia with features of LSNA. So we sort of, by convention, LSNA is confined to the papillary dermis. Morphia gets into the reticular dermis, and sometimes you can see features of both. If you look at it clinically with LSNA, usually you're going to see this kind of cigarette paper wrinkling and whatnot. But sometimes you do a biopsy if something looks like this, and it's got the morphia beneath it. So hard to be sure when you're just looking at it clinically as to which of the two you're dealing with. Here's an example of the hemorrhagic blister. And here's another non-hemorrhagic bulla that develops. So it's not always just purely cleft. It actually can form a real bulla in a lot of these cases. So that is bullous LSNA. Okay. So basically you've all seen the features here. And really the only other thing I would throw in the differential here would also be lupus. You can get sclerosis of the papillary dermis sometimes in LE. It's not as common, but you actually sometimes can get sclerosis of the collagen in lupus, and you can actually get sclerosis of the collagen in chondrodermatitis nodularis helicis. Okay, so this is an easy one for maybe so we're doing these are kind of easy for the first year residents so they don't feel totally lost. But we've got a shave biopsy here, neoplasm, benign, right? Small, symmetrical, well circumscribed. We can see the bottom of it here. So we've got the whole thing. This whole thing was a little tiny papule. And it's comprised of these epithelial cells. So this is an epithelial neoplasm. And what kind of epithelium are we looking at here? So here's squamous epithelium. We've got maybe a little follicle over here, and now we've got a higher magnification. And what kind of differentiation is this? So this is epithelium now, but what kind of epithelium is this? And it's glandular epithelium, and we have really just three major glands in our skin. We have eccrine glands, apocrine glands, and then we have sebaceous glands. There's some other glands elsewhere, but those are the three main ones that we have in our skin. So of those three, which one is this? Well, it's obviously, it's got the bubbly cytoplasm. It's got the little stellate nuclei here with these little small gossamer strands of I guess, cytoplasm probably, or nucleoplasm here. They're in there. So this is sebaceous, classic. And sebaceous actually will also undergo holocrine secretion, which you see going on over here. So this is a benign adnexal neoplasm with sebaceous differentiation. Notice the shape of this. It's got a cup shape to it. So whenever you see a cup-shaped papule that's comprised of more than 50% mature sebaceous elements, and here is some on this side, or some of these more primitive germinative cells. So remember, the sebaceous gland is made up of these little basophilic cells at the base of the sebaceous gland. So these are the stem cells, germ cells that produce the actual gland. So they actually come off of the matricle of the mantle zone of the follicle. So that's where the little sebaceous cells come off of. Those are the stem cells that lead to the follicle. That's where the apocrine glands form. They all form that mantle zone. So there are all these little, basophilic stem cells that Dr. Lay was talking about a few weeks ago in his lecture. So they're forming mature sebaceous cells. Sometimes you get neoplasms that are comprised almost wholly of those cells. So a sebaceous lesion can either be mostly mature cells, greater than 50%, or greater than 50% of the immature cells. And so when we see greater than 50% of the mature cells, and it's forming a little cup-shaped lesion like that, what do we call, what's the diagnosis in that case? Anybody know? Sebaceous adenoma, that's good. Now, if we see mostly the immature cells, what do we call that? That's called a little different name to it. Sebaceoma, yeah. And there's actually some other, some people talk about sebaceous epitheliomas and atypical sebaceous epitheliomas, those kind of things. Those are kind of when they sort of don't obey the, read the textbook very well, and they're larger. Maybe there's a little bit of slight asymmetry, and maybe we're saying, well, could this lesion be evolving towards the sebaceous carcinoma, or does it have some atypical features? That's kind of when we use those terms. But usually they're pretty easy to tell from one another. And I want to make sure you remember that the size is critical. If you get a sebaceoma and you start looking at it at higher magnification and you see mitotic figures, which you're going to see because stem cells have mitosis because they're reproducing and they're forming glands. So they're rapidly maturing, reproducing cells. That's not a criterion for the diagnosis of cancer. You need to have the other architectural features. So I see a lot of these lesions way overdiagnosed as sebaceous carcinoma when somebody may have a syndrome. And what syndrome's associated with multiple sebaceumas and with multiple sebaceous adenomas? Hopefully everybody knows, good, the MUIR-TORRE syndrome. You do not want to call every sebaceoma or every sebaceous adenoma a sebaceous carcinoma in a patient that's got a syndrome. That's not good. It's not good for the patient. It's inaccurate, and it's not correct. It's not what's going on there. Just like you wouldn't want to call every neurofibroma a neurofibrosarcoma in a patient that's got neurofibromatosis. And what are you going to do? Excise every single one of them when they got 1,000 lesions? So same thing is true here. And you do need to know what the MUIR-TORRE syndrome is. And there's one other thing that we often look for in these lesions to kind of help us make the diagnosis of MUIR-TORRE. We will look for microsatellite instability. So we're looking for loss of expression of things like MLH1, MSH2, MSH6, PMS1. We look for loss of those markers. And you can still have the MUIR-TORRE syndrome without loss of the markers. And sometimes you can get loss of just one, or you can get loss of three, or even all of them. But you do need to at least think about MUIR-TORRE when you get patients that have multiple lesions like this, especially. So make sure you know what the features of the MUIR-TORRE syndrome are. The board is almost certainly, you're going to encounter that. You'll probably almost certainly be asked something about that on the board, so you may as well know what it is. And then the differential diagnosis would include other sebaceous lesions, sebaceous hyperplasia, but that usually doesn't give you that nice cup-shaped morphology. There's usually follicles associated with it, so that would not be the best diagnosis if you saw that specific case. Okay, let's take a look at this one. So here we've got probably an excisional biopsy, and we're going to go higher magnification. And this cut, yeah, I guess it's okay. It's not as good as some that we see, but I guess it's reasonable. Probably when we got the recuts, there were some sections that showed more of this change than we're seeing here. But you can see you can start working through it. So we've got a lesion in the dermis that once again is an epithelial line cystic structure. It's got a cyst to it. Okay, so this is an epithelial line cyst. And what's the lining of this cyst? It's not as good as some that we see. It's got stratified squamous epithelium, but it's also got these little immature hair follicles that are radiating away at the periphery of the cyst. You got one there, you got another one here, and I think probably in one of the other sections we may have had a lot more of those. So let's pretend that we had 50 of these instead of just 2. So what's the most likely diagnosis when you're looking at that? You have trichofolliculoma. That's good. So you think of trichofolliculoma as like a cyst, and it's like kind of like a little pinwheel, if you will, or a Ferris wheel. It's got the little tiny miniature follicles kind of radiating off the central part of it. And then in the center of it, you'll see this little white tuft of hair, in these cases. So that's a trichofolliculoma. And some people split off and have some other kind of things they call folliculocystic hamartoma and that sort of thing. You don't need to know that. If you see something that looks like a cyst and it's got these radiating little follicles coming off the side of it, that's the right diagnosis for your purposes. So don't worry about other things like that. If you don't see the little radiating cysts, it may be a dilated pore of Weiner. So these things are kind of you can think of them as being in a spectrum. They're probably really aren't in a spectrum, but you can kind of think of them as a spectrum. That dilated pore of Weiner is a cyst. It's just got this sort of reticulated, proliferation at the periphery, but it doesn't make the immature follicles, and you get trichofolliculoma that makes the follicles, and then if you get little small cysts that sort of form together, you start thinking of pilar sheath acanthoma. So all of these things are kind of related to one another. But this is a pretty classic trichofolliculoma clinically, and they usually do have this little tuft of hair coming out of the center of it. It's often a little white the tuft of wool, it's been described as. So that's pretty straightforward. So that is trichofolliculoma. So just remember that. And again, these are totally benign lesions. They don't really need to be removed. Just the key is just to make sure that you don't miss the diagnosis. Now, occasionally you'll see one of these rather than getting the little immature sort of follicles where you get the papillomesenchymal bodies and the inferior portion of the follicle. You'll see mostly sebaceous glands there, and the same distribution, the same sort of orientation, kind of looking like a little pinwheel, if you will. So there is a sebaceous trichofolliculoma, and there's a sebaceous keratoacanthoma also. Those have also been associated with MUIR-TORRE in some cases too, just so you'll know. Okay, so here's another one. Different situation here. So is this inflammatory or a neoplastic process? Even at low magnification, you can see that it's neoplastic. Is it benign or malignant? Well, we don't have the entire thing, but let's assume that this is the bulk of the process. So you can draw a line down the middle of it. It pretty much looks similar on one side than the other. The other thing you can do too, if you've got a punch out of a very large lesion, is look at the individual aggregations. So are these individual aggregations small? Are they symmetrical? Are they well circumscribed? Just like the PALISADED encapsulated neuroma, those individual little aggregations were themselves recapitulating benign lesions just on their own. So is it epithelial or non-epithelial? Well, once again, it doesn't have a spindle-shaped morphology, so our first reflex then is to say it's more likely to be epithelium. And we want to ask ourselves what type of epithelium. So we've had sebaceous epithelium today, we've had squamous epithelium today, we've had follicular epithelium today. So we need to have one other type of epithelium, right, to be kind of complete. And as we go to higher magnification, we've got these very monomorphous cuboidal cells that are basophilic, and also some of them have a little slight clear staining to their cytoplasm. So this is very characteristic of one specific type of differentiation. I don't know if anybody knows what type it is, but it's very characteristic of this pattern, where the cells are very monomorphous. I wouldn't say ductal, because ductal is right here. Ductal is just means that there's evidence of a small duct in the lesion, like an epithelial lined ductal structure like over here. But these are not ductal. These are more coming from a structure type of gland that it's associated with ducts. But when you see individual cells that are very monomorphous, we refer to that as poroid differentiation. And that's thought to be ecrine differentiation. This is a variant of ecrine differentiation. So we go back to lower magnification once again. So if you think of this as a poroid lesion, there's 4 lesions that have poroid differentiation to them. So the most common one, or the classic prototypical one, when we use the name in there, is going to be what? What's going to give you the most common? Yeah, ecrine poroma. Okay, so that's basically, think of that as just this big warty lesion that's connected to the epidermis. And then we get poroid hydradenoma. We get hydroacanthoma simplex, which is almost kind of like a poroma in situ, where you just get these same kind of cells are just kind of filling the epidermis over a broad front. And then when you get the cells that look like they are like those of a poroma, but they've broken off of the epidermis, and they're sitting down here, they've gone rogue, if you will, and they're in the dermis, we call that a dermal duct tumor in that situation. So this is an example of a poroid lesion in the family of the poroid entities that we just talked about. So make sure you know what those are. Make sure you know how to recognize the cells. The cells are very, very monomorphous, just like this. Monomorphous, cuboidal. Some of the cells, a little bit of a clear cytoplasm. They got a little bit of glycogen in there. You remember the cells that are secreting your sweat, or they have they're making ATP. They're undergoing glycolysis. So they're using that glycogen for that purpose. So basically, you've got that recapitulated in the actual neoplasm. So you look at some of them, clinically, nobody ever gets this. I mean, sending as rule-out basal cells or something like that, so they're nondescript. Firm nodule, they're not painful, so it's not one of the painful tumors. So just remember, basically, poroid lesion in the dermis, no epidermal contiguity, think of dermal duct tumor. Okay, let's take a look at this one. So got a lot of neoplasms today. Maybe next time we'll do more inflammatory things for you guys, but we're hitting some neoplasms here. So we've got a shave biopsy, and we've got something again. Would you call this symmetrical or asymmetrical? Very symmetrical, very small, so and very well circumscribed. Kind of draw a line around this whole thing. So it's pretty much about the same size as that sebaceous adenoma we had a few minutes ago. And let's go to higher magnification. And is it epithelial or non-epithelial? Well, once again, it's epithelial, the differentiation. And what type of epithelium is it recapitulating? Well, here we've got a couple different types of epithelium. We've once again got these basaloid cells out here. We've got these little small these pearls here, these squamous eddies. Whenever you see squamous eddies like this, we have the keratin pearls earlier than that squamous cell carcinoma. But in this case, if you've got squamous eddies, that tends to favor benign. So squamous eddies, benign. Keratin pearls, that just means it's kind of undergoing cornification. That can be seen in a squamous cell or in benign lesion also. But you see squamous eddies, you should think about that as a benign process in all likelihood. But there's other features here that favor benign: the size, the symmetry. If you look at this area over here, you've got these fine, small basophilic cells at the periphery. You've got a little kind of glassy basal membrane zone surrounding this, and you've got some what looks like some clear cells over here as well. So this is recapitulating a part of a hair follicle, and it's recapitulating the outer root sheath of the follicle. So we've got that over there. And then we're going to look over this area, and we've got these more squamous areas, and then maybe some abortive papillary mesenchymal bodies over here. We've got, once again, some little small squamous areas here undergoing cornification. We don't have any atypical cells, no mitotic figures, no acantholysis, none of those things we saw before. So this is also exhibiting a different portion of the follicle. This is probably maybe at the lower part of the infundibulum and probably right around the upper part of the isthmus, and maybe the mantle zone is being recapitulated here. So this is a benign lesion. It's also follicular. Anybody knowing what the diagnosis would be here? Yeah, basaloid follicular hamartoma. Good. And it's not all basaloid. It's got the basaloid part's kind of over here. In this area, I think just if you call it benign follicular hamartoma is probably, you're fine, because it's got areas over here that almost look like kind of what we see in an inverted follicular keratosis. So we see like things that look like a wart in a way. Architecture looks like a wart, and you see the squamous eddies. Think of inverted follicular keratosis. If you see, looks like a wart, but it's got more of the outer root sheath of the follicle, tricholemmal differentiation, this kind of thing over here, then you might think it's more kind of a just a generalized tricholemmal verruca, if you will. So, but still, it's benign. I'm not sure this is a verruca. A lot of people call them that, but certainly it's in that category of benign follicular hamartoma with some basaloid follicular hamartoma area to it. Once again, you do a biopsy of this, looks maybe something like this. This might be somebody that's got trichoeps, but this actually is one entity where you can get multiple lesions. So there is a benign basaloid follicular hamartoma syndrome, just like there is a multiple trichoepithelioma syndrome. So they both can be seen in a syndromic fashion. So basaloid follicular hamartoma, benign follicular hamartoma, whatever you want to call it. And basically the difference will include other entities that you see here. But when you've got these factors that you just, we've been through, you can really pretty much make the diagnosis. Okay, this one, it's not a very good specimen, but I think the reason we put it in here is because it's so rare. And I think it was cut through and used multiple times. But anyway, you can at least see what's going on here. This may be the best piece over here. Let me turn this over for you. Yeah, so this was one piece, but it kind of fragmented. So we're dealing with an inflammatory neoplastic process. Well, let's go to higher magnification, and you can see there's something going on here. These are not inflammatory cells, so they don't belong here. This is abnormal. These are epithelial cells. They're sitting in the dermis, and they're pretty far away from the epidermis. So here's another area over here. If we just had this piece alone, you could still make the diagnosis or certainly suspect the diagnosis. So it's a neoplasm, and there's no epidermal contiguity. So whenever you see a neoplasm sitting in the dermis, if it's epithelial, go to higher magnification, which does seem to be epithelial. Remember, epithelial cells are they're usually cuboidal, and they usually hug each other pretty closely. So this would be a malignant epithelial neoplasm. And yes, so Steve's put in there metastatic, and that's exactly right. Whenever you see a lot of neoplastic cells in the dermis without any contiguity, you should think about the possibility of metastatic neoplasia. And here, you see that little structure right there? That's an actual lymphatic. And this is also a blood vessel or lymphatic up here. You've got the neoplastic cells inside the lumen of that. If you see that, then you know you're dealing with a metastasis. So this is a metastatic epithelial neoplasm. Now, that's as far as you need to go, most likely. There are a couple that the board might ask you to kind of maybe know about a little bit. If you see one that looks like a lot of glands with dirty necrosis in the center of the glands and the lumen of the gland, that's more commonly seen with a colon cancer. If you see the diffuse pattern between among collagen metals in the dermis, the so-called Indian file pattern, that's classic for metastatic breast carcinoma. This one does not have either of those two patterns. These are just clusters of atypical cells. This patient actually turned out to have metastatic bladder carcinoma. So you wouldn't know that. You don't need to know that. All you really need to know is that it's a metastasis. And this patient actually metastasized to their finger. It's a pretty rare situation. That almost never happens, but it can happen. Obviously, the most common locations. Generally, if you're going to deal with a metastatic carcinoma, it usually kind of likes to metastasize close to where it started. So we see people that get metastatic bladder cancer, metastatic prostate cancer. It's usually in the groin area when it presents in the skin. Metastatic lung cancer usually presents in the chest area. So just remember that. But the scalp is a very common site of metastatic lesions also. Metastatic renal cell carcinoma commonly goes to the scalp. It's usually a very bloody, almost pulsatile, vascular lesion. And that's one that is got a characteristic clinical feature to it. So there's a few the board might expect you kind of know a little bit about, but this is not one of them. So you don't need to know much about metastatic breast cancer or bladder cancer. So one of our more fellows who is a pathologist put this in. It's good to know, but mainly it's only good to know that it's just a metastatic neoplasm. Okay, let's take a look at what we have here. All right, so we got a incisional biopsy, nice large biopsy in this situation. And we've got, again, a neoplastic process. Line down the middle, looks benign, some contiguity to the epidermis, but there's also some things going on in the dermis. Would this more likely to be epithelial or non-epithelial? Okay, well, most likely epithelial. And let's see if we can figure out what kind of epithelium it's differentiating towards. So once again, we've got these cells that are kind of clear staining here. They're cuboidal as well. So maybe once again, we're dealing with an adnexal neoplasm. And are these, so again, ask yourself, okay, if it's an adnexal neoplasm in the skin, there's really only 3 or 4 things that can really do that. I mean, you're talking about if it's either going to be sebaceous, it's going to be eccrine, it's going to be apocrine, it's going to be follicular. Which of those is it likely to be? So once again, you've got clear cells with some admixed little cuboidal cells. So maybe once again, we're dealing with an eccrine or apocrine neoplasm here. This one's got some epidermal contiguity up here in some areas. They don't always have to have, but this one did have it, just in this case. Let's take a look at the other side. And so this is another example. A lot of times you'll get these, they just kind of look like cysts, or they're kind of deep nodular lesions in the skin. So with our magnification, it looks pretty much the same on this side as it does on the other side. You got some thick pink collagen bundles associated with it. So this is an example of a nodular hydradenoma. So this is another adnexal neoplasm. This is very common to see these big, thick keloidal collagen bundles in these lesions. The cuboidal cells admixed with the clear cells. This isn't what I would call a poroid hydradenoma. I probably just call this generally a nodular hydradenoma, or maybe even a clear cell hydradenoma, because in a lot of these areas there are clear cell features like you see here. But this is an example, again, of a benign adnexal neoplasm with eccrine or possibly apocrine differentiation. So once they become solid like this, it's really hard to tell, because you can get it in an apocrine lesion. You can also get the same kind of morphology of these cells. If you scroll around, you actually were to see a duct that's got some apocrine differentiation in it, perhaps, then you can sort of say, well, that means it's more likely an apocrine lesion. We don't really have much of that here, but just make sure, if you look at the slide, this is a nice example of a variant of a hydradenoma. Okay, you don't really need to get into all the different subtypes of those so much. Just know that basically it is an adnexal neoplasm with eccrine or apocrine differentiation. And these are benign. If you leave them alone long enough, they can rarely become malignant. So that's one reason why we often excise them. If you don't get them all out, they will recur, they can ooze and ulcerate and things like that. So those are just some reasons that they're often excised, but they don't go into, they don't really develop into cancer very frequently at all. Can, but rare. Okay, shave biopsy from near volar skin once again. Notice that there's no follicles here. So this is not just lichen simplex chronicus. Hopefully you could appreciate that this lesion, it's a shave biopsy, and it kind of almost looks like a little sessile or maybe pedunculated lesion. So you can think of this clinically, it's going to be like near volar skin, and it's going to be a little bump. It's not going to be just thick cornified layer. This is an elevated little papule. And if you go to higher magnification, there's some abnormality of the collagen bundles inside the center of the lesion. There's too many fibroblasts. There's some fascicles of these cells. There's some dilated blood vessels. And then the epidermis is thickened. It's got a thick cornified layer to it. It almost looks warty, but this is obviously not a verruca vulgaris. So I don't know if anybody knew what the diagnosis was here. Good. This is an acquired digital fibro, the fibrotic component, keratoma, which is the verrucous epithelial hyperplasia component. So the name is good. It fits. It's acquired. Usually comes on sometime, usually in infancy or whatever, but it can come on later in life too. And when you see them clinically, they kind of look like this, look like these little bumps like this. Now, the differential diagnosis, something like this would be an accessory digit. These can also occur kind of down in this area. And when they do, the differential diagnosis of those become the angiofibromas associated with tuberous sclerosis. So make sure that you know the difference between those lesions and this lesion. Those generally have a more myxoid stroma. They have many more blood vessels in them. They don't really have quite the thick fibrotic fascicles of spindle cells that interweave that you see with acquired digital fibrokeratoma. But this is what they look like. And the differential diagnosis also would include an accessory digit, supernumerary digit. When you biopsy those, you see evidence of a traumatic neuroma inside there, or sometimes you can actually see the cartilage and the bone that's forming there. So that's in the differential diagnosis of acquired digital fibrokeratoma. So hopefully everybody got this right, pretty straightforward, and the board is likely to ask you something about that. The last case is kind of cute in a way. This is, I don't know, you're not going to get anything like this where they show you 6 little papules, but the patient had one of these lesions. We've already seen something like this today, so hopefully you guys can recognize this as well, this one's still sebaceous adenoma. You're close, but it's got more of the inferior, the stem cells, so you're close. Still got 50%. There's another one over here. This is B. This one is different. What's the diagnosis here? It's a shaved biopsy. We can't assess anything about structure or symmetry or anything like that. But we can see that it seems to be an endophytic. And if we had multiple sections, we might see a little cup-shaped invagination here. So this is a keratoacanthoma. So if we have a sebaceous adenoma, a keratoacanthoma, and then this last lesion here. Now, which one is this one? So now we've got all of the cells are the inferior little primitive stem cells that are forming this lesion. Notice how small it is still. So this isn't a carcinoma, it's still a papule. This is the sebaceoma. So we have sebaceous adenoma, keratoacanthoma, and a sebaceoma, all from the same patient. So now you don't really need to do microsatellite instability. You know good and well the patient's got to have the MUIR-TORRE syndrome. So I think they wanted to just kind of show you sebaceoma earlier and then say, now we got one patient that actually had the syndrome. And he had a KA here, and he had a little sebaceoma up here, and maybe a sebaceous adenoma over here. So that's what you see with MUIR-TORRE. They get multiple lesions. They don't just get one lesion. And they can show anything. I mean, you never know for sure when you biopsy one of those which one it's going to be. In my experience, sebaciomas tend to be a little bit more kind of yellowish than the sebaceous adenomas. They're yellow too, but not quite as yellow. They're yellow-orange for some reason when they're sebaciomas. I'm not sure why that would be, because their cells are more blue under the microscope, but they tend to have a little more erythema, a little bit more orangey color than a sebaceous adenoma, which is more commonly skin-colored or slightly yellow. So anyway, but make sure you know the non-polyposis colon cancer associated with that. That's the important neoplasm to understand. So you can get they don't have to be colon cancers. They can get other things too, urothelial, breast. So just realize that you need to know all of the various kind of cancers that can be associated with that. So we do this panel of stains on these patients. We're looking for loss of some of these markers as opposed to things like aneuploidy, like a melanoma. Here, this is kind of analogous to a BAC1 mutated nevus, where you're looking for loss of the staining. Okay, good. So we've been through a lot of lesions, a lot of adnexal stuff today. So next time, maybe we'll focus more on a lot of inflammatory things. But I think you can see these were benign, symmetrical, all these fairly straightforward lesions, and just notice the different types of epithelium, different types of differentiation. Go back and look at these slides and make sure you feel comfortable with recognizing poroid ductal dermal duct tumor differentiation, the differentiation in that follicular hamartoma that had both the inferior, had the tricholimal differentiation off the side, looks like the outer root sheath, and then the nodular hydradenoma that had the clear staining areas with the cuboidal cells, which is very common in those lesions too. So I hope you enjoyed the session. Hope everybody got something out of it. And we will see you guys next time. So thanks again.